now is not the time for a webinar. That was 2009. For over 10 years at Tubules, we've been bringing dentistry together without bias. Sometimes we've been misunderstood. Our path was blocked because people thought we were self-serving, but our purpose has always been bigger than just us. It's always been about cohesion. It's for those who selflessly share and those who inspire each other. It's for those who want to grow and look out for each other on the way. Our webinars evolved to live streaming Tubules Live and our hands-on roadshows. Our study clubs have been bristling hubs of activity all over the country, growing together. Fast forward to this most recent challenge sent to test all our resilience. In a storm, we rely on what built us. In the immediate grief, we created Tubules Live Aid, advice on how to cope and how to heal the wounds. What next? Now is our time for bringing dentistry together with the same spirit. The profession needs unity, don't you think? We launched the new dedicated Tubules Live Aid section on our website. Open access and free for all. Tubules Live Together sessions, bundling all of the Tubules spirit into real conversations with real people daily. Tubules-minded experts helping to restart our journey ahead. A discussion area to share worries, concerns, and selflessly share advice and support. Sign up today. No credit card details required for base membership and access the power of Tubules togetherness.
And that is Tubules togetherness, coming together to help each other move in these times when we all have to. It was really amazing, actually, to watch 4 people come together who have taken the crux of the clinical teaching for this Tubules Live Together. We had Nick Sethi, the fun guy, the guy with the funniest videos on Facebook with the best presentations on these areas. Sanjay Sethi with amazing clinical cases, Elaine Moe making sure that she's following in their footsteps very well. And of course, the one person who started this all off last Friday, Dr. Riaz Yar. His first Tubules Live Together has now reached well over 1,000 views and got that much engagement. It's brilliant because Riaz is kind of almost like this cup. You see, you can't see it, but it has a massive impact. And the topic he's going to talk about today is the same like this cup, something you can't see, but is extremely important. All you can see is that logo attached on his sleeve. And for that purpose, we introduce to you today's host. Well, he was the presenter on Tuesday. He became the funny guy on Facebook on Wednesday. He got serious on Thursday. And guess what? He's back here today, hosting today, Nick. Welcome to the show again, Nick. How are you?
I'm great, buddy. It's nicer to be on this side of it than doing the teaching. This is way more relaxed. It's great to be here.
It's super to see you again. I think today's going to be fun, isn't it? It's a topic we all always think about, don't know what to do. How do we go about it? So it'd be really, really cool, isn't it?
This is great. And, you know, it's one of those topics where we see a lot of lectures on how to make things look pretty, how to make things look stunning anatomy-wise, and that's all good. But how does it work in our patient's mouth? Not just our photos for Facebook. You know, what happens when the patient leaves? How are they chewing? How are they contacting on the restorations we provide? And it's something that to this day, I don't think is generally taught very well. Occlusion is this voodoo subject that, you know, only the masters are allowed to talk about. And we had the pleasure of having Riaz come and talk to us at the practice last year. And I was blown away. Number one, he's just a super cool dude. Number two, just the way he gets his point across, so methodical, extremely well thought out. And for the first time in 10 years, I think I actually understood occlusion. Well, some of it, Riaz would say, not all of it.
I mean, you've got to give the guy dedication because he was stuck in Barbados for so long and he was still delivering the education for us, right? If anyone saw his webinar last week, fortunately, I think he managed to get a flight back.
He's on the flight at the moment, as you'll see in a second. He's actually piloting the plane, as you.
This explains the headphones then as well. But before we bring him on board, I've just got to make sure that I inform everybody about the CPD, because we do get that being asked. When you go on the website on Tubules, on the top right, you will see IPDP. And when you actually go on IPDP, click on Add Goals, and on your PDP, go on growth goals, and underneath there, you will see a growth goal called occlusion. It's probably a bit further down. I'd have to find it. Well, we've created it. There it is, occlusion, and add it to your learning cycle. To the end of today, when you want CPD, just go on the online CPD area. You will see the Dental Geeks page. And the Dental Geeks page is where we are then hosting the CPD part of it. I'll show you how this works later on. But floor's over to Nick and Riaz to take you through this fun afternoon.
Guys, thank you so much for spending this glorious Friday. What day is it? I don't even know what day it is. Friday, Saturday? I've lost all track of time. Whatever day it is, the sun is shining. Drew, you guys have done an amazing, amazing thing with Tubules Live Aid, covering clinical mastery, business mastery, mental mastery, everything. You somehow cover all bases, and we are proud to be part of it. As we've said all along with the Geek Out Study Club, we are not doing any of this for any profit or monetary gain at all. This is purely to keep our spirits up, keep people happy. And if we can raise some money for charity, we're now asking you to get in contact with Steve Campbell and Ashley Burns, who are printing face mask visors. So if you could please do a donation for them, that would be wonderful. But now it's over to the main man, Riaz. This guy is just going to blow us away. It's a lovely, lovely lecture. Really, really clear take-home messages. How do we accurately adjust our occlusion? Do we know what we're looking for? Do we understand our articulating paper? You know, this is something I've learned a lot from Riaz, so I'm looking forward to it. Riaz, you just have to unmute your audio, I think, buddy, and the floor is all yours, and enjoy, my friend.
Hi guys, thank you again, Nick, and thank you again, Drew. You always embarrass me. I always go a little bit purple when you guys start talking about me. A lot of this is because I've made thousands of mistakes. So it's just that issue of when you make a mistake, you sort of think about it and you could I have done differently. Well, let's get started with it. Quite an important topic. So I'm going to just share the screen you all. Hi to everyone. Again, thank you for coming to share Geeking in Lockdown with us all. And we just really want to reiterate what everyone said about this being a really great time, great opportunity to learn. But also we need to give something back to those that are doing other things like helping the NHS, such as Ashley Burns and Steve Campbell for and all their support. So thank you to them, and thank you to Drew, thank you to Nick again for embarrassing me as usual. Right, okay, let's get started. So occlusion, we sort of, us as practitioners, we're looking for these dots. And that tells us a lot, but do we really understand what those dots actually mean? So we've got to go back a step and think about the system that teeth are involved with and the main jobs that it's involved with. I know certainly on the graduate level, we talk a lot about enamel, dentine, and the pulp. We talk a lot about the bone, the soft tissue element, and the periodontal ligament. And we tend to sort of skim over a little bit the system that actually it works within. So the three main physiological jobs of teeth are mastication, obviously to break the food down, once it's broken down, to swallow that food, and they're also heavily involved with phonetics. But then there's also a pathological element to that as well. And those teeth can also be involved in parafunction, but also hypernormal function. And that is such as habits, nail biting. It can be chewing gum. It can be anything that overuses that system and therefore starts to cause some complications within it. So when we come to then assess that system, really, for me, quite critical is that we understand why we do what we do. So when you're asking your patient to move their jaw left and right, the whole reason for that, or even protrusively, is because they are the dynamic contacts involved in, for example, incision, biting the food, that is protrusive guidance. When we're looking at moving the jaw to the right, that is masticatory movements on that side. But then why do we movement when we get our teeth to tap together? That is because those are the swallowing contacts for that patient. And then phonetics in itself is quite crucial, especially in incisally, where if saying certain letters, have we put the incisors in the right place to ensure that we're not hitting those teeth and creating a problem within the system. And then same importantly, if the patient is a parafunctioner, then we really want to get enough stable contacts on the whole system so the forces are distributed evenly within that system so they don't break. And same for dynamic, they're either parafunctioning dynamically or statically. So that's a little bit of understanding of the system. Now, most of you will have seen some sort of video that I've been creating over the last 6 to 8 months on a device called Modjaw, which allows digitally now for us to analyze a little more that we design and we restore. So if we look at this analysis, this is me analyzing mastication, and I need to know my end goal, but I also need to know what their chewing cycle is like now, because I'm potentially going to change that, but I want to know if I'm going to change that for good or am I going to change that for the negative. The patient has a crossbite, so it's slightly more challenging case. You may have seen that in the treatment planning webinar that we did, where I was talking about desirability, suitability, and affordability. This is now that data collection for the patient, and I'm going to design the occlusion. In the bottom right point of the slide, you can see the interincisal point, and that tells us about the vertical and horizontal movement of the mandible in relation to teeth. It's designed to break the food down. So I get them to chew on the right side first, analyze the chewing cycle on the right, and then I analyze the chewing cycle on the left. And then we look to see whether we can improve that or at least keep it the same or worse. Now, over the years, because I am a bit of a geek when it comes to occlusion, slowly people recognize that when they have a problem with a patient who has an occlusal issue, they tend to recommend them, and I tend to see them at this point. So this was a little case here where the patient had had a crown done. He'd had a root canal done on the upper left 6, and then he'd had it restored with a metal crown. But listen to the video. Now, we talked about the jobs teeth are involved with. So what if we then introduce something new which the system wasn't used to, and how can the patient react to that? So remember the 3 jobs: chewing, swallowing, and phonetics.
Basically, I found I couldn't chew on this side because it was just a single point. So you can't chew on that side. So I was forced to chew on the right hand side, where my teeth no longer met properly. There was obviously like a fairly considerable gap. And actually with soft food, that's not an issue, but we made the mistake of having a beef stir fry, and it actually meant effectively I couldn't chew all the way through strips of beef. So I had to take them out and cut them into very small pieces, or swallow them in larger segments than I wanted to.
Wow,
and all at the same time, you're still
How did you
find
swallowing? How did you find swallowing food? Did you find that was okay? Or did you feel that was different?
I felt it was difficult. It's difficult, isn't it? Because it's a holistic process. Because it was more difficult to swallow because you couldn't chew the food as thoroughly.
Yeah.
You have a tendency not to, well, because your teeth don't meet. Obviously, you can't bite down. I did notice when I first had it done, I noticed it actually made a difference to my speech. When it was, because it was quite a bit bigger than it is now, and I could feel it pressing against the inside of my cheek, and I actually spoke a bit like this for the first few days until I got it redone, and so it did make a difference.
Did you find that you were catching your cheek as well? Or?
Yeah.
And sort of thing.
It feels abnormally large.
So that just reiterates the point about making sure that if we are going to introduce something new into the system, and it may just be an onlay, it may be a crown, it may be a composite restoration. We really want to make sure we don't change the system as long as the system in itself is healthy and there are no issues with it.
Yeah, sorry, do you mind if I just ask a quick question?
Yeah, sure.
The video was cutting quite a bit there for some reason. I know we're trying to work the stream. I know you are lecturing from a plane with your headphones on. Do you mind maybe just reinforcing what the salient points from that video were, because we couldn't quite catch it, if you don't mind?
No problem, you could let me know. So the gentleman had a crown done on the upper left 6, and that crown wasn't designed to fit with his existing occlusal scheme. So it was proud, it was a super occluded restoration. So what the patient noticed straight away was that the right side of his teeth didn't meet. So that when it came to then breaking his food down, he said when it was soft food, not a major issue. But then he made the mistake beef stir fry. What that meant was psychologically, he had to chew and apply more force to break the food down. A consequence of that was he was not able to break the food to a reasonable size, which also then had an effect on his swallowing, because he was then swallowing a larger clump size, which is not what he's used to. There was then a consequence of when he had it done that his speech was affected. So he made a little picture where he was like twitching a little bit. He felt that he couldn't talk properly. He just felt that it was alien in his mouth. So then the question, is that clear?
Yeah, yeah, for sure. That was clear. Just one thing I forgot to mention, guys, is if you do have any questions during, please message Elaine or make some comments in the comment box below, and we'll make sure we get them answered afterwards. Thanks, Riaz.
No worries. So how did that happen? How did he end up with a super occluded restoration? So what I'm going to sort of share with you today is a process to try and ensure that that doesn't happen. So we don't hit that point where the patient, in this case, the patient has left that practice and has now come to see me to try and get it rectified. But he did go back and see the dentist to try and adjust it. They adjusted it. You could see from the picture that it was heavily adjusted, but it still didn't feel right. And so there was just an issue of confidence there. The patient's not going to complain. It's not going to go medical legal, because personally, I won't allow that. I'll just rectify it and make sure that, you know, it doesn't escalate to that. But the issue for the patient is that he's lost confidence. So I want to be able to share with you ways that you can ensure that you go from point A to point B without causing any of these complications, but also still having the confidence of the patient. Now, for you to be able to do that, you need the equipment, you need the right equipment. And this may sound sort of silly, but I am really keeping it as basic as possible and just building from the simple foundations to the end point. So you need some Miller's forceps and you need articulating paper. Now you can see in that picture at the bottom right, there's 3 Miller's forceps: blue, red and white. So the blue and red are for your static and dynamic contacts, and the white is to dry the teeth. Now that really is important, that we use something to absorb the moisture so we have a better color transfer. Now Bosch articulating paper has an element in there called transculase, which allows for transfer of color in a wet environment, but I still prefer an impeccably dry environment. The question then is, if you're using articulating paper with forceps, what is it about articulating paper that we need to know? What limitations do we have? So we know that we can use it, but also not trust it implicitly because it has some flaws within it. So first question you need to ask yourself is, which thickness do we need to use for our patients and why? We also need to look at understanding the difference between what is actually a contact, so the cusp is touching that tooth, and what is a smear, which is just simply a consequence of putting color paper in between teeth, and you will get some transfer of color onto surfaces that aren't in contact. And then we need to know about the force. How do you know that your patients are applying the same forces when they tap? so that you've got a standardization. Can it be done? And you've then got to be able to interpret that as well. And I'll show you a really good paper, 2 papers actually that look about it, that analyze interpretation of occlusal contacts. So step 1 is to dry the teeth. And when you dry the teeth, you can then get the patient to tap their teeth together. Now, the literature, a good paper on looking at articulating paper is by Brasilo Velasco, which looked at the influence of articulating paper thickness on occlusal contacts. A really nice paper in 2015. So I sort of took it a step further and just took pictures of contacts with different thickness articulating paper. So what thickness would this be? This is 200 microns. So what we see here is distal buccal, mesial buccal of the 7, distal buccal and distal lingual of the 6, marginal ridge and buccal cusp contacts of the 5, and a buccal cusp contact of the 4. So we have some data on that tooth. What does that tell us? What do we do with that? Do we take all of it away? What is the consequence of using 200 microns? What you may notice here is that we actually have greater color transfer now, but actually the thickness of the paper was thinner. So what happened there? What caused greater color transfer, but the paper was thinner? And this is force. I got the patient to bite harder on 100 microns, which meant that we got more color transfer. It didn't necessarily mean it was prouder. It just meant, wow, we've got more color transfer. So is that better? Or is 200 microns better? What about 40 microns? Why do we use 40 microns? Why don't we use 200? These are the questions you should be asking yourself. What about this? Should we use this? This is 20 microns. Why do we use 20 microns? Why don't we use 200 microns? So to answer that question, we'll look at a scenario. So if this scenario where we've used 20 micron articulating paper, if we did a class 2 composite on the lower right 5 and it was proud and we got the patient to tap together, that would be the surface area that would get color transfer. So what that means is that would be the area you would reduce. And if you reduce that small amount, it means you're going to be precise, you're going to be conservative, and there's going to be less chance of making the restoration infraoccluded. But if you were to do the same situation, so exactly the same size cavity, same size restoration, but we're using 200 microns or 100 microns or 40 microns, you will get greater color transfer, and therefore you will take more material away. And that means your restoration will become infraoccluded and you create some instability long term. And I'll show you some pictures of what happens long term. We also use foil, and there's a reason why we use foil as well. Now, foil, shim stock foil is 8 microns thick. The teeth can only sense 15 to 20 microns, so it's half the size of your periodontal ligament. So the patients won't even sense this. Why we use this is because of these 2 things. So we look at Kirstein and Sutter's paper. The problem we have with articulating paper and color transfer is that we are poor at understanding it, and it's actually irrespective of whether you're 20 years experienced or 5 years experienced. It doesn't even matter how many occlusal courses you've done. We are poor at differentiating between the occlusal force and actually the occlusal contact. So we don't know how much force has been applied on that articulating paper to give that contact. So that's our limitation. Now, if that's the limitation, what foil does is it allows us to assess occlusal contacts irrespective of color. So if there's a contact there, it will hold the foil. Then we use color paper to find out where that contact is. So what we're doing with foil is actually combining the limitations with articulating paper and trying to have another system in place to make sure we get the right adjustment, the right data, and we don't make the restoration info occluded. So that then leads on to occlusal contacts. So if you've got the right equipment, you need to understand morphology of teeth. And there are two types of occlusal contacts. And this is just to simplify it. In class 1, it can be class 3, but obviously starting at cross bites, you will get a change in the type of occlusal contacts. But the two most common type of occlusal contacts are going to be cusp tip to marginal ridge and cusp tip to fossa. So once you understand that, you are then looking for that in your analysis of the system. So when we look at this picture here, this is reiterating where your supporting cusps would give contacts in the opposing tooth. For example, the lower right 4 or the lower 4 supporting cusp, which is the buccal cusp, would hit the marginal ridge of the same tooth in the opposing arch and one tooth forward. So the 4 would hit the mesial marginal ridge of the 4 and the distal marginal ridge of the 3. The same for the 5, buccal cusp would hit the mesial 5 and the distal marginal ridge of the 4, and we move our way across.
Riaz, can I just ask a quick question?
Sure.
Because this is really interesting. This only became really apparent to me a few years ago. So when we have contacts on an incline, so we should be having cusp tip and fossa. When we have a contact on an incline, is that where we need to be looking to adjust, even if the tooth hasn't been restored? So you have patients, for example, myself, I have, well, you remember we did Fradiani's together. Mauro had a look at me and noticed I had a premature contact. Is there a link between, well, first of all, when do you suggest that we consider adjusting inclined contacts? And secondly, if there is a contact on the incline, do you feel that might have an effect on possible things like bruxism?
Okay, so incline contacts per se in natural dentition aren't a problem unless the contact time on that incline contact is for progressive time. So if they are power functioning, then it can potentially become a problem. But again, it's diagnosis. So if a patient comes in with a totally intact dentition, but he's got pain on an upper right 6 and you can't find any other reason, we start looking at the occlusion and we start looking to see where the contacts are. And yes, sometimes there can be a contact on the incline, and that's creating a crack ultimately. And you'll understand that when I show you the slide in the next couple of slides, the next one in a minute actually. So leading on, let me actually show that to you. So leading on to that, what we really want is ideally 2-point contact from a supporting cusp. So what we mean by that is the supporting cusp, let's say the mesial buccal cusp of the 6, needs to be hitting the marginal ridge of the opposing 6, but the mesial palatal cusp of the 6 needs to also be hitting the fossa of that. So in this situation like this, we are getting at least 2-point contact, and the forces then are being transmitted down the long axis of the tooth. Now, if you do a restoration, or the teeth, you've had orthodontics, for example, done, which I don't know, Nick, have you had orthodontics done?
Yes, I have actually. And interestingly, I feel that part of the problem of my premature contact is a slight relapse and a slight narrowing of my upper arch. Maybe that's changed.
Possible. So what's happened is the forces have changed, but let's use orthodontics, or let's use a restoration as a case scenario. So let's say you do a restoration and you're doing it on the lower tooth. So the upper tooth still has the same contact because you haven't changed the upper tooth, but you've done a class 1 composite and you haven't given the right shape. So what's happened is now you've put an incline contact like that. Orthodontics can do the same. If you don't give the same contact, the teeth will rotate, and the forces then get transmitted at an incline, and then slowly over time, you create cracks, and then they start to get symptoms. And it can be crack cusp-like symptoms, pulpitic-like symptoms. So why we want to try and maintain 2-point contact is to maintain stability of the teeth so they don't move, but also to make sure the forces are being transmitted. If you had a restoration, we talked about this, or I think I've talked about this in the past, where restorations are great with compressive forces, but not tensile forces. So if you give an incline contact, the forces become tensile rather than compressive, and then that causes the restoration to fail sooner rather than later.
Riaz, I've just had a good friend of ours, Nishan Dixit, current president of BACD, who's just said to me that my arch isn't narrowed, my mouth is as big as ever. So thanks very much for that, Nishan. Appreciate it.
We both know you very well. So if we look at now transfer of color, we look at articulating paper and what can happen. You can see here we've got a lot of transfer of color onto here. We need to be able to understand what is a smear and what is a true contact. So you can see that there's transfer of color by just placing it. That is not where the teeth touch, but what we can see is where the clear contacts are. So that contact there on the right is the buccal cusp of the 4. The other contact is the buccal cusp of the 5. Again, good stable contacts from our opposing dentition. But we do need to understand a little bit about forces and why forces have an effect on what we do. And what's important about forces is duration, as well as the amount of forces that we apply. So a patient who's, for example, a static clencher will put a lot of forces on the teeth, but also for a longer duration. And same with patient who bruxes. And then that has an effect on the teeth. It has an effect on the muscles, has an effect on the joints. It also has an effect psychologically for the patient as well, because then they start to feel pain. But I've always tried to help people understand what force means. And when we think about newtons, or we think about force in pounds, what does that actually feel like? So to give you an idea, if you look at the left column and it talks about pounds of force, mastication force-wise is about 2 to 40 pounds of force. Now, 1 pound of force, if you go onto YouTube, because again, being a geek, the way to find out what 1 pound of force feels like is to actually hold 2 Snickers bars. And how that works out is a Snickers bar is 50 grams of weight. 2 Snickers bars is 100 grams of weight. 100 grams, actually using the physics equation, is equivalent to 1 pound of force. So if you ever want to think about what mastication force is, it's basically maximum mastication is 80 Snickers bars. And then if you want to look at someone who clenches on the molar, for example, 205, that's 410 Snickers bars. So it gives you an idea of how much weight of force that actually is. So there is an issue here with force. We need to make sure then forces are being transmitted through the restoration in a compressive way, because it can have an effect. So this is generally my protocol, and it's a crucial protocol, because it means that we don't change the system if we are conforming within the system. So we dry the teeth. So we do a pre-assessment. We look at the static and dynamic contacts. You then do what treatment you need, and then you reassess the occlusion, making sure you haven't changed it or even improved it. Because if a patient comes in with a fractured tooth, then you're not going to leave them in for occluded because they're fractured. You're going to replace the contacts, but you're going to make sure you assess all the contacts adjacent to that restoration.
I think this slide is so important. I remember when you first got this concept into my head, the fact that we're not taking enough photos of the preoperative occlusion and comparing it. We're just taking the post-op, showing contact points that look like composites in occlusion, but I don't necessarily know if that's how they were beforehand. And that's something you put into my head. And I encourage everyone to remember that, because that's made a big difference in making me adjust and knowing where I'm accurate or not.
Yeah, and you know, when you used to send me pictures and sort of thing, the first thing, I mean, the work always looked amazing. So I was never really having to feedback about the aesthetics or the anatomy or the margin. That was never an issue for me. It was always, well, what was the occlusion like before? And you'd go silent, and it always used to make me giggle. Yeah. It's like, you know, I wouldn't get an answer back. But if we are assessing the occlusion before and then we assess it afterwards and it's high, we need to know how to adjust that occlusion. And this is the protocol that I stress to everyone, that you need to know the equipment that you're using. So like millers and articulating paper, you have millers, you've got articulating paper. I'm hoping now you understand why you use articulating paper, why you use foil. Now you need to know why you use certain diamond burrs to adjust the occlusion. Because if you're using 40 micron articulating paper, you need to use the same grit diamond burr, because if you don't, you're taking away more material than the actual articulating paper is assessing you for. So you'll just make the restoration infra-occluded. You need to look at the company that you use your diamond burrs, because everyone is different. This is the company that I use. So extra fine is 25 micron grit, red is 46 micron grit, and blue and green have their own diamond grit. But this is a lovely picture by a gentleman called Daniel Capello. So I've borrowed this from him. This is showing the diamond grit on a red and a green. Can you see how aggressive the red is? So you will take material away. And if you compare that to green, look at how aggressive that diamond burr is. It will take away substantially more tooth material or more restorative material. Therefore, you're going to be infra-occluded. How we do that as well, I'm going to talk about that in a minute, but if I just reiterate this case in point. So this was a case where we were simply doing 3 zirconia crowns in the upper left arch. That's what they look like. I've cemented these in. I know my pre-assessment occlusion, but this is what I've noticed is from that pre-assessment, this restoration in particular is proud. How we know that is a combination of articulated paper and foil. So the foil is still holding on the 3 and the 4, for example, but the 5 and 6, it's infra-occluded by 8 microns. So I need to adjust this high spot to bring all the teeth into occlusion. How do you adjust a high spot? So using, in this case here, I'm using red articulating paper, which is 20 microns, and I'm using a 25 micron grit diamond at a slow speed. I'm going to talk about the speed in a bit. So what we do is we simply take away the outer rim of it first. So we're trying to reduce the surface area of that contact. So it ends up with a small point like that. And then I take that away finally. So I don't just take it away in one point. The reason for that is I'm trying to keep the shape of the restoration and not make it flat. We take that away and we take that other one away because that restoration is proud. So now I've reduced the intensity of the force on that restoration, and I now check again and look what happens. We've now got contacts. We've introduced a contact on the distal ridge. We've still got the same contacts, but you can see that the surface area of that contact is less, and the patient can sense that straight away. The other teeth are now contacting more evenly.
Riaz, that's such a good point. Do you mind just running through that one more time, just if anyone missed that, because that has made such a big difference in my practice. If you could just maybe...
I'll do that. I'm gonna show you. Let me show you some more slides, and then if we need to go back, then tell me if you feel it needs more. But let me show you some more slides to sort of reiterate that point, because I know that is quite an important point. So what we've done is we've simply reduced the amount of contact force on that by reducing the intensity of that restoration, and we've done that by doing that. So that's a superimposed image of it, and we've simply done it in 3 steps. But what that means is, if you look at this slide here, so we have a pre-assessment and occlusion. So if we had 2-point contact. When we did our restoration, you put a crown on that, for example, we now have a proud contact on that. So now what you have is 1-point contact, but you're now not having the other point contact because it's proud in 1 point. So that is a supra-occluded restoration. So we need to adjust that area. You can see that that's out of contact. So we need to now reduce that contact down. So we get the diamond burr and we're trying to replicate the shape. So you're not making it flat. So you see here that the burr is angled at the inclines of the tooth like that. So we end up with a sharper point, and then we do a final adjustment to give it that rounded shape. So we end up now with a restoration that has a similar shape to what it was before. We haven't made it flat. We've copied the inclined shape, so that now both teeth touching back again. Did that make sense?
Yeah, I got that. You got some great people watching as well. I'll just quickly tell you, we've had some good comments already. We've had Nadeem, president of Bards, say that he doesn't like Snickers, he prefers Mars bars. So can you tell him how much it is in Mars bars, the force?
Well, Mars are 52 grams, so it would be a little bit less.
Yeah, I trust you to know that. And we've had absolute legend in dentistry, David Winkler, has made a comment, which is great. Dave Garber said decades ago that occlusal lectures have turned into a competition of who can show the most black, red, and blue spots. I think you're making this nice and clear, the fact that it's not just about how many contacts, it's making sure you've got the right contacts. And this little bit about adjusting is just great. So sorry, I thought
no. Thank you for applying more pressure and reminding me that all these guys are watching me as well.
I thought you'd like that.
yeah, thank you. So again, just reiterating how we adjust a tooth. So handpiece speed needs to be low, so 45,000 revs. Normally you're talking about anything between 150 to 280,000 revs per minute, depending on what motor you have. So you can see that when we are adjusting, we drop the speed right down so that we are taking away less tooth material. So whenever you're adjusting, your speed of handpiece needs to be low. You also need to use the right diamond grit with your articulating paper, so them two have to be linked together. So this is a case, again, these are implants. Now some of clinicians who are involved in implant dentistry may do their occlusion where if they follow the ITI guidelines, they are infra-occluded. I personally don't. So I assess the patient as an individual, and if I think those patients need a dentate occlusion, that's what I will give them. And this patient is one of those patients. So it's about adopting a protocol for each patient. But the principles are the same. So these 3 implant crowns, they've not been done by myself. Patient has been referred to me to look at the occlusion because the patient has reacted to it. And just on a simple assessment, so a pre-assessment, we've done some markings. So what we notice straight away is that the occlusal contacts are only on those 3 restorations. But I did stress that we need to look at static and dynamic. So what we notice straight away is that the dynamic contacts are also on these restorations. And when we look at the shim stock hold, because I don't trust articulating paper entirely, the shim stock hold is not holding on any of the teeth. So the second molar and the canine are not holding any paper, and also the opposite side is not holding any paper either. So we've now got a true super-occluded restoration. This just reiterates that point I've talking about keeping the inclines of teeth when you're adjusting. So when you have the shape of your restoration, we need to make sure that if it's proud, we are following that inclination. So we drop the inclination infra-occlusally. So when you look at these pictures, when I'm adjusting it, because it's a 2-dimensional picture, I'm actually holding the bear at the inclines of teeth. So I'm not making them flat. I'm actually copying the shape like that, copying the shape like that, copy. And then now that's a fossa contact. So I can use the rugby ball shape to create that. Incline contact, incline, fossa contact. So just by doing that at a slow speed, I've reduced the intensity of the contacts, and now we're getting contacts on the natural teeth.
Riaz, can I just one quick thing in between? We've had another question just relating to this. If you've got, this is when you're adjusting a super occluded tooth, we've had a message from Zara, which is a good question, that if you've got a tooth that's already super occluded at the start and shim stock holding on those teeth, but not the adjacent ones, when you restore that tooth, would you copy the design, or would you then be dropping that occlusion to bring in contacts on the adjacent teeth? It's a good question.
Yes, yeah, no, you have to, if you just think of the system as an engineering system, if one tooth is super occluded, then that means that tooth is taking all the forces. That will cause ultimately failure of that tooth. So you do need to bring all the other teeth into play if it's possible. And that, again, if you, that sort of scenario is where you're going to have teeth in really unusual positions, that, and the patient may have adapted to that, but that, you know, classically, in the experience that I've got with patients who have malocclusions, I will always try and give more information to the brain, because that's always going to be better than less information. So I always go for the positive rather than the negative, and one contact would always be seen as a negative contact.
And would you adjust that dry or wet when you're adjusting these, for example, these crowns?
This crown's always wet.
Okay.
Yeah, always wet. But what you do, that you get the contacts dry. So you first dry paper, tap, tap, tap. You now have the color. You then take away with water, because obviously with zirconia or any material, you don't want it. You don't want to damage the material.
So yeah, absolutely. And Neil Jaswell, sorry, this is great. So many people are. You've obviously got a great topic here, because people are desperate to get the questions in. Again, when you are adjusting these contacts, another great question from Neil Jaswell. Are you doing this with the patient lying down or with them sitting up? And does this make a difference?
Absolutely, yeah, I do both. So I will do the initial adjustment lying down because it's easier, but I always do the final check sitting up.
Thanks, mate.
Yeah, really good question, because that posture we know for certain. Now, how does posture create the changing contacts? There's great CBCT data by Javier Vasquez looking at posture and position of your C1 and C2 and position, and that has an effect on mandibular position. So now we are more confident when it comes to posture assessment. And so more and more now, a lot of our reorganized bites are not taken in supine position, they're taken in a seated upright position, because that's where they are. Now, if you make a splint for the patient, you will make that in a lying position, because that's when they're parafunctioning. They sleep, they wear that splint when they're asleep. So I try and do all my occlusion with the patient in their functional position. They don't eat lying down, they eat sitting up. So all my final adjustments are done sitting up, and everything like a splint is done lying down, because they tend to wear that splint at night. And so you'd want to do it in their functional position.
What a great little tip. That's really good. Cheers.
This is dynamic occlusion. So I've taken that down. It's moved on to the 6 and 5. So you could argue that functionally it would be better to have those contacts there. But again, it's implants. So I would, if it was natural teeth, I would have kept them. But in implants, I like to have the forces on natural teeth, not on the implant teeth. So I've now taken them away, and you can see now that we have the contacts back on the teeth and the implants. I've done the shim stock test afterwards, because we knew from a pre-assessment there was no holes, and now you can see very clearly that we have shim stock holes on the natural teeth. But what's really important is we also have it on the implant restorations as well. And that, for the patient who can sense that difference, I will give them an actual dentate occlusion with implants. So I don't treat them like they were any other teeth. I just treat them like normal teeth. And more importantly, on the opposite side, this is contacts, because you have two joints joined by one bone, so you can have an effect on the opposite side if you don't restore it correctly.
And based on that,
we are done.
Oh wow! Okay, amazing. Oh mate, we're not done, because you're getting questions left, right, and centre here. Red. That was superb. Really lovely comments, and some great little nuggets there. We've got a chap, Gianmarco De Andrea. I hope I said that right. Apologies if I didn't. When adjusting the occlusion, how do you decide whether you need to add or take away if the other side, if the opposing arch has reasonable contacts across the teeth? I'm not sure if they mean, how do you know whether to adjust the lower or the upper? Let's say if you've got both of them that are crowned, possibly.
Well, you'd always adjust the restoration that you put in first. But if the shape of that restoration is correct and the opposing crown, the restoration of that shape is incorrect, then I would correct the opposing crown. But that is your pre-assessment. So I think the main answer to that question is understanding occlusal morphology. Because if, for example, you're replacing the lower right 6, then you know that there should be a contact from the mesiobuccal cusp, the distobuccal cusp, and there should be at least a fossa contact on that restoration. So if, for example, the mesiobuccal cusp, if you're doing a composite and the mesiobuccal cusp is not giving a contact, you would add onto the mesiobuccal cusp to build that up to give a contact.
Excellent.
That is, you've got to recognize that whenever you restore a single tooth dentistry, you always have to look at the opposing arch, because I can show you composites which I could not design to be beautiful because the opposing arch of the large amalgam restoration very deep, very close to the pulp. So it meant that I'd had to accept the incorrect anatomy on that, but I couldn't improve on the anatomy of my existing restoration. I had to stick with what it was. So sometimes in your pre-assessment, what you should spot is, do I need to restore 2 teeth or just 1 teeth to improve the occlusion in that area? And that's why a lot of the more experienced guys, when we're doing more dentistry, that's not because we want to financially it's not a financial decision at all. It's always a biological decision, trying to make sure that we can control the occlusion and the aesthetics and the functionality of that restoration. And you can only do that sometimes by replacing both restorations, because otherwise it's a compromise.
Brilliant. Do you know what I love is that it's one of the hottest days in the year and you are absolutely getting questions flooded in. So something about this Geeking Out squad is working, because people are appreciating short, intense webinars. Just get the golden nuggets and then enjoy the rest of your day. We don't do 2-3 hour jobs here. This is great because our vision was exactly that, and people seem to be enjoying that. All right, let's crack on with some more questions, Riaz. Saeed Nazimi, thank you. This was great. What was the ideal articulating paper to use in the end? Did you mention that, or
yeah,
do you have
20? Yeah, 20 is the ideal because it means the most precise. The one that I use is by Prestige Dental, and it's accurate microns. I have all others, but actually for anything restorative, there's always red and black are my most common contacts. I play around with 40 microns for teaching so that you can see what 40 microns look like, but I prefer the AccuFilm. And then you can even get 12 microns if you want to be even more precise. So again, it's the thing with contacts is interpretation that I've combined with articulating paper is a safer process.
Sanj has got a question, and it's a good question actually. When you are adjusting, no, it's okay. When you're adjusting occlusion, especially something like zirconia, the surface you leave is going to be rough. So if you get your occlusion perfect and it's rough, and then you polish it, do you then have the danger of leaving it infra-occluded, because by polishing you end up actually reducing it a bit more? Yeah,
you do. It's inadvertent. That's why you've got to assess. But polishing takes away substantially less. So even when you should be using obviously the polishing kit that you have, and at a lower speed, so I'm not taking away as much. So if a diamond will take away 20 micron worth of material at 45,000 revs per minute, the process of elimination, slow speed or rubber wheels should be taken away maybe 5 to 10 microns. And again, it depends on pressure. If you're applying a lot of pressure, you will take more material away and risk infra-occluding the restoration.
Excellent.
But you do need to polish it. Yeah, I mean, that I should have mentioned that they were polished afterwards.
No, it's just it's a good point. And Rob's just weighed in as well, saying that typically he would adjust, polish, recheck, adjust, polish, recheck. And I think that's a sensible way, probably, if you'd agree, to flow from that.
Yeah, absolutely. Yeah, I think with Rob, Rob does more implant work, so that's a different conversation I'm happy to have with Rob, because my protocol for implant occlusion isn't the ITI guidelines. It's something that I've developed myself. So just analyzing each patient and giving a prescription for that patient.
All right. So we've got another question for us mere mortals that don't have this mod jaw machine that you've got, which is super cool. How do we best record these movements? And are we purely relying on just having a look at study models? Is there any tips you can give us for checking or what to look for with our dynamic occlusion?
When you say recording, are you talking about bite registration material, or are we talking about how you assess looking at articulating paper?
I guess how you assess looking at articulating paper, and also when the patient, I mean, quite a lot of the time when I've cemented an onlay, for example, it's noting that when the patient actually closes completely, the restoration will be in good contact. But if there's a slight prematurity as they come in, it might just hit and slightly slide very slightly. And we learned this from, well, I learned this from Maurits, you've probably known this years ago, but if you could maybe just give us some advice on how we would pick that slight slide up and ways that we could do that without mod jaw.
I mean, mod jaw isn't really going to help you in those situations anyway, if I'm being honest. That's going to be just sort of drying the teeth. It's all just the very basic of it, drying the teeth, right occlusal thickness paper, but getting the patient slowly so that you can spot that first contact. So you've got to do it. It's a process, but the key is you want color transfer at that first point contact. You're only going to get that if it's dry and you've got the right articulate paper, and you've just got to do it slowly. If you as soon as first stop, then slowly adjust using that protocol of keep the incline right and not making it flat.
Excellent. All right, Daniel Theo, thanks for your question. We've got two questions actually. And Daniel has asked, can you reliably adjust zirconia in this way with these fine burrs as it is such a tough material? That's the first question. And secondly, if you are adjusting zirconia, how do you then address the lack of glazing, which we know the answer to this is an interesting answer. How do you address the issue of glazing and the wear risk on the opposing teeth? I'll let you handle that one.
Thank you. I'll let you answer the polishing one.
All right. Fine. Day off for you.
Well, I know the answer, but I know you know the answer as well. So I'll let you sort of answer that. So the first question was, can you adjust using diamonds? And yes, you can. And actually, the advantage anyway is that you know, unless you start applying a lot of pressure, you're not going to take too much away, and that's actually what you don't want to do anyway. So the fact that it's a harder material, great. That's not an issue for me. The issue is polishing. So whether there's numerous and hundreds of people, and I'll let Nick give his viewpoint as well. Glazing, how long it lasts post with cementation, there's debate on that, whether it lasts 30 days, some say less, some say longer. That's number one. Number two, when you do adjust it, you know, actually the loss of glaze, does that cause more abrasion on the natural dentition? So the key is for me is that it must be polished, because unpolished zirconia and even unglazed zirconia can cause will more abrasion of the opposing enamel. So it needs to be polished. I'll let Nick come in because this is his forte as well.
Well, it's interesting because there's good evidence to suggest that polished zirconia, the wear rate on opposing teeth is actually quite favorable. And the problem with glazed zirconia, as Riaz alluded to, is the minute that glaze has gone, the zirconia underneath is actually quite abrasive. So if it's polished in a really predictable way, at our practice, we use the indirect ASAP polishers. They're really good. And like Riaz said, you start off with a rough grit and progress down to a fine grit. You don't just adjust with a rough burr and then go straight to a polishing cup. It's, you know, you're not going to get the result you want. I think you'd agree, Riaz.
Yeah. I see Rob is going to be joining the conversation. Uh-oh.
We've got a surprise for you. We've got Rob Aretti, who's decided to weigh in here. So this is going to be fun. Rob, get your video on, mate. Let's see your pretty Italian face.
There he is.
Hello, Rob.
Oh, Rob looking really good.
Can you see me?
We can see you, buddy. You're in. Okay, let's hear it.
Is that Momo?
We're all in.
We're all in. How you doing, Rob?
Yeah, no, I couldn't give any comments, or they just seemed to go into a separate thing with Narni, and they didn't seem to come up with everyone else's. Don't know.
I think they've blocked you on purpose, Rob, because we know the questions are a bit too hard.
Yeah. Rob, can you ask your question that you mentioned about the incisal edge or the incisal cingulum?
Yeah, I got a lot of questions really, but the implant one, I agree with you. I don't agree with ITI at all on that.
Yeah, me neither.
Pointless leaving them shim stock light, because within 6 months they're in shim stock anyway. I mean, just over erupt, but then you've got unpredictability on how they've erupted and how they've contacted.
Exactly.
My question is more, I totally agree with Neil that you should always sit patients up. I think you
Absolutely.
it's ridiculous not to, because the contacts are different.
Yeah, they are.
I have a couple of questions. So one is, we all keep going on about static, and when we say dynamic and we say to patients just move sideways and grind, again, it's not the real deal. My question to you is, one, I tend to get them to chew on the articulating paper like it's chewing gum.
Yeah.
Think of it like chewing gum. So they're making true motions on the restoration. But another one I think is really important, I want to ask your opinion on, is the morphology of the upper anterior restorations palatally. So I see so many crowns without really any cingulum type of morphology, a very mild sort of convexity. And when we adjust those crowns, we can lose that and give them a slope. And I think over eruption of lower incisors is a big issue. And I think a lot of crowns that have been snapped off with the core inside is yes, not enough tooth structure, but this type of force, this over eruption of lower incisors, and no control over the anterior guidance. So back to you, Riaz. Sorry.
Okay. No. I think I'm going to go back a step. Which of the two teeth erupt first in the mouth? The adult teeth. It's the incisors and the first molars. And there's a reason for that, because biology tells us a lot about our system. Canines are important, but those that know me know that I am, canine guidance, I refute it, but that's a different debate anyway. But that I refute it based on biology. And we underestimate two teeth. We underestimate the first molar, and we underestimate, just 1 minute, I'm just gonna exit just 1 second because I've been asked to start video again. There you go, I'm back again. All right, hi guys. Now, so what that tells you about those two teeth, the central incisors and the first molars, they are actually crucial in our chewing and setting our chewing cycle, setting our data for our system. So setting what are called the central pattern generators. And that's why for me, central incisors are crucial that we get them right, both palatally, because palatally is function, labial is aesthetics. The incisal edge is a combination of function and aesthetics. So when you look at I have a picture of the central incisor, and we never underestimate the palatal aspect, because that is crucial to incision of the food. And so if you change that palatal aspect and you do get over eruption, you've changed the forces. Now, anterior teeth take tensile forces and they can handle it because the distance from the fulcrum is further away. But when you start to change that trajectory, you can cause problems. So yeah, we can never underestimate. I'd happily sort of talk about central incisors till you could all go to sleep, but it's crucial. I don't know if that answers the question though.
I've got some more. We've got some more. God, this is great. We've got at least 4 BARD presidents on. We've got a BACD president. I don't know what other webinars you pull this kind of power on. So well done to all involved. This is superb.
Stop putting pressure on me.
Nah, mate, you can handle it. You're superb. What are the flaws of adjusting composite with a white stone?
Sorry? What was the question?
Well, I suppose, is there a flaw? Is there a problem with adjusting composite with a white stone? My guess would be it's especially if you're not using it wet, you generate heat quite quick, and composite and rotary instruments with dry burrs, it tends to disturb the matrix filler surface, and you can end up degrading the surface character and quality.
I mean, we have water coming through our slow speed as well, so it's not an issue for me personally. It's just that the amount you're going to take away, you just got to keep checking the occlusion. That's all.
What about chewing on the articulating paper, Riaz?
So yeah, I don't use articulating paper to chew with. I use a different type of paper. It's actually a you can buy it off Amazon, but it's actually a writing type paper, which is total 30 microns, and you fold it over. If I show you that, you will see that it gives you better transfer of color for chewing contacts. So whenever I come to do analysis of chewing, I don't use articulating paper because you have two different colors. So what I find is that this paper by it's basically a paper type articulating film. It's about 50 microns, and you fold it so it becomes 30. You will see that gives you much better color transfer, so you're able to understand. But the key here is understanding morphology in mastication, because in mastication the guiding surfaces are actually if you look at the morphology of the tooth, so on the upper, it would be the inner incline of your buccal cusp, and your outer incline of your palatal cusp is what your cycle in contacts are. And this is where we have a problem. When we come to do dynamic assessment, we will only normally have cycle in contacts off the buccals, off the inner incline of the buccal cusp, when we really want also the outer incline of the palatal cusp guiding that chewing in. But actually breaking food down is your cycle out contacts. So when I talk about mastication and I talk about designing teeth, you have to design them so you have cycle in on two surfaces and cycle out on two surfaces. And that means your food breakdown is much more efficient. So when you see that, I've got a picture of a slide which shows the difference in cuspal angles if you use a average value articulator and if you use the modular data, and you'll see the total difference in shape of teeth from normal average value stuff to what we do now. And that is more efficient. That's what we want, is an efficient system.
I'm going to ask you one more, then we'll agree on our to keep it nice, short and sweet, which is, this has been brilliant. I mean, the conversation is cracking. When do you know if it's better to leave a restoration dial, so i.e. slightly high and let it dial in, or adjust? And that's from Marvish Khan.
Okay, really good question. Dial, I never dial in on a single tooth. That's one rule of thumb. I do dial, but I can show you probably, well, actually now probably I can show you occlusal contacts pre-dial and occlusal contacts post-dial using digital and articulating paper assessment. What I've noticed that my question when people were using dial was, do we actually improve the occlusal contacts if we just get them to bite on 3 to 3 and let all the posteriors over erupt and the low incisors intrude? And no one knew the answer to the question. I've done 3 cases now where one case we dialed the anteriors, and then I scanned her every 3 months digitally to see how the occlusal contacts were over time. And actually in this patient, the occlusal contacts were better.
Nice.
So what that says in one case, now in the other 2 cases, we're finding that they are getting back to the similar contacts. But what we don't want to do is create incline contacts that weren't there before with dial. And no one knows the answer to this question, because I've looked over the years, and I remember Alex Milosevic, who was doing dial since the beginning. And there's never been a true analysis of whether the occlusion is better afterwards if you were to dial them. So in this one case I've shown it's improved it. We've got better contacts. And in some of the cases I've had to add a few more restorations to improve the contacts. So we've replaced a crown because we've done the dial. all the other teeth are touching, but this one isn't moving. So we've then done another restoration to improve the occlusion.
Fantastic. Rob, mate, you look good with the beard as well.
I was going to say,
Doll. I'm into Tarkadol.
you look good, buddy. Drew has said he wants to get one last one in, and it's a good one as well. Would you recommend using an articulating paper with different colors on each side so you could ascertain a true contact and when you've got a high contact?
I think once you're comfortable with articulating paper, it really doesn't matter. It's because you understand what a true contact is. So once you understand occlusal morphology and where teeth should be touching, then it doesn't really matter what color you use to find that contact. What's important is that you have the right thickness. And if you are adjusting, you're using the same grit diamond burr to not take away excessive material. So they're more important. You're drying the teeth. The color is helpful in the beginning because what you're trying to do is look at static and dynamic and see the difference in color. And that helps you understand. But once you've got to a point where you're comfortable with articulating paper, the color actually just becomes a secondary point. It's not actually what drives you. You're able to interpret dynamic and static.
Amazing. Well, I have to say, it's been another cracking one. This is the fourth one we've done, and we've covered such a lovely range of topics, from treatment planning, from compromised internal whitening and management of resorption.
It's been really good. Thank you, Nick. And Rob, it's good to see you. I'm glad.
It's been great.
I haven't seen your face for a long time, Nick.
Rob, you're going to have to jump on a few more, mate. You're going to have to be our surprise guest. Come in with a question. One of my favorite things about Sundays growing up was watching Top of the Pops and watching the top tips. So top hits of the day. So Sanjay and I this Sunday, we're going to change things up a little bit, and we're going to bring our Top of the Pops top 10 hits for anterior composites. It's going to be caps, sunglasses, old school style. Going to have some real fun with it. Quick fire round, top 10 tips. Rob, you're welcome to come and harass us with your questions as always. Beautiful to see you.
I'm going to show you how to chop a carrot. I'm going to do a little video on how to chop veg. How
Mate,
about that?
I would love that. That would be superb. Riaz,
risotto.
That was fantastic. Thank you so much for everyone that's tuned in. We had
thank you guys. Thanks for coming.
Hundreds of viewers. It's an incredible response we're getting. We literally have just done this just to inspire people while they're sitting at home. Drew has given us a wonderful platform to do this. We do not do this for any form of financial gain. We are asking you, please, 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 dig deep and donate some money. Contact Ashley Burns and Steve Campbell, who are raising money for PPE, for printing visors for hospitals at this desperate time. That's all we ask in return. We are loving doing this with Tubules. Tubules Live Aid has just been fantastic, a range of topics. Make sure you tune in every day for the others. And don't forget to tune in with us Sunday at 2:30 p.m. for the top 10 hips. Drew, back to you, my friend, and we'll see you then.
I expect some fun bits. Rob, you were talking about risotto. I guess if Rob is still around. Before Sunday, we have something really, really interesting. Tubules Live Together is about education, empowering you, and bringing us all together. So let me just share what tomorrow's Tubules Live is bringing for David Horn. If you can hear.
Hey Tubulites, it's David Horn with a sneak preview of a fun Tubules Live event that we've got coming up on Saturday at 5 p.m. We are going to do a Tubules Live on wine tasting. Okay? Wine tasting, yes! So, it's going to be fun, it's going to be easygoing, it's going to be chilled, and I'll take you through the process of how you taste wine and what you look for and how do you identify the different flavors and things in wine. What I'd love you to do, if you want to participate, is get a bottle of white wine and get a bottle of red wine and have them ready with a glass each. So you want to have a glass of wine for your white wine, you want to have a glass of wine for your red wine. If you have separate glasses, that's great. So this is a white wine glass, And this is a red wine glass. Yours may be in different shapes and sizes, but typically a red wine glass is larger, rounder, fuller than a white wine glass. But if you don't have separate glasses, you've just got one set of glasses, that's fine too. Just make sure you got two glasses.
And
Oh, he's gone.
there we are.
Bring
that was
pint
Rob.
glasses.
There we are, Rob. He's going to be talking a bit about wine there, and I know you like your wine, as many of them do.
I'm already ready to go. So.
Brilliant. Well, what David was trying there was the magic trick, but he was trying it with his own self. That's why I kept coming and going. Next week, Rebecca Howarth on Saturday is also going to do a cookout session. She's going through MasterChef on Tubules Live Together. So we're bringing everything in this fun bit. So Elaine, Tubules cooking class is coming next Saturday as well. You've got clinical mastery, you've got professional mastery, you've even got wine and cooking coming with these series. So it's been awesome. Nick, Sunday, I think we better do top 10 tips on composite with wine, because we'll have got some expertise there. What do you think?
I'm down for it. We're doing anteriors, and then Elaine's going to do the posteriors one soon after next week. So let's more excuses. Hey, this is great.
Brilliant. And Riaz, this is absolutely phenomenal. I mean, the comments, the feedback, the questions, everything that has come together. People have really, really loved this. Dave, Matthew, can I access the previous webinars in this series? Absolutely. You can go to the Tubules Live Aid section, and they are available to view for everybody. Just donate to your charity of choice. Steve Campbell and Ashley Byrne are doing an amazing job. I've also just been informed that the critical care unit at the Royal London Hospital in East London is out of surgical gowns. If anybody knows any, please, has any surgical gowns, please get in touch. Rob, absolute brilliant to see you here as well. Nice surprise. Gandalf, if we were the Lord of the Rings, you would be Gandalf. Which would be really cool with a beard. Nick, I guess you and I will have to sort out who the hobbits are.
Definitely, mate.
And we'll let the rest of them work out. This has been Tubules Live, beaming from our isolated areas, working together. Riaz, once again, thank you very much. We will see you all on Sunday. I hope your flight lands okay, Riaz. I hope your flight lands okay back into London. And we'll see you in London.
I'm flying it, so yeah, just keep praying.
Keep it going. Then thank you very much, Nick. I will be finishing this live stream at this point. Have a good afternoon, everybody.